Welcome to the San Francisco Interfaith Council online briefing for faith leaders. Today's program will focus on the status of public health orders and public worship. This event is hosted by the San Francisco Interfaith Council and supported by the Joint Information Center of the San Francisco COVID Command Center. The audio, video, and chat will be monitored and recorded for record keeping, training purposes, and quality assurance. By default, all participants will be muted and video turned off to minimize distractions. To submit a question or comment, please select the chat button at the bottom of your screen and send a message to Q&A. Your questions will be collected and shared with the Interfaith Council after the meeting for response. A reminder to get tested. To learn more about eligibility and details, please call 311 or visit sf.gov/gettestedsf. Ongoing stress from the pandemic, racial injustice, wildfires, and grief and loss are real. Maintaining our social connections can be a lifesaver. If you could use help managing feelings like depression and anxiety, reach out to the Mental Health Talk Line at 855-845-7415 or text the word HOME, H-O-M-E, to 741-741 and connect with a crisis counselor. Once again, welcome to the San Francisco Interfaith Council online briefing for faith leaders. And now it is my great pleasure to hand it over to Michael Pappas, the Executive Director of the SFIC.
Thank you, Lynn, and thank you to our tech team for all you do to help make these online briefings possible. Good morning, I'm Michael Pappas, and on behalf of the San Francisco Interfaith Council, I want to welcome you to this morning's online briefing for faith leaders, hosted by the San Francisco Interfaith Council and supported by the COVID Command Center's Joint Information Center Virtual Outreach Team. In an effort to allay confusion and bring about greater clarity concerning the impact COVID-19 related San Francisco health orders are having on our city's communities of faith, San Francisco Health Officer Dr. Tomas Aragon will brief our city's faith leaders on why and how public health orders, directives, and guidances are developed, their legal significance, what references the new order makes to worship, houses of worship, and other religious facilities, and the relationship a county health order has to the guidances issued by the state of California. This particular briefing will depart from the established format. In lieu of panel discussion, following Dr. Aragon's presentation, he will respond to questions submitted in advance by San Francisco faith leaders. And now it gives me great pleasure to welcome the chairman of the board of the San Francisco Interfaith Council, who will offer a word of welcome on behalf of the board, the interfaith statement, and an opening prayer.
Thank you, Michael. Good morning. My name is Kaushik. On behalf of the board, I do want to welcome everyone to this morning's conversation. Before we got started, Michael mentioned that this is the 25th weekly conversation we've had, which I think is incredible. And I want to, as I try to always do, acknowledge our two amazing staff members, Michael Pappas and Cynthia Zamboukas, who have been doing so much since the shelter in place first began. It feels like every week we join you, a new challenge has been added in our world that we have to face and address. And I think this week is certainly no different, given what was supposed to be a debate happened a couple nights ago. We're reminded of the many absurdities of our world right now. I'm very grateful to be in a place like the Bay Area, and I want to give a really special thanks to this morning's guest speaker. I can't think of a more timely topic, and Dr. Aragon, thank you so much for joining us and sharing your thoughts with us this morning. For those of you who are joining a Interfaith Council meeting or event for the first time, I want to extend a special welcome to you. At the beginning of every interfaith meeting or gathering that we have, there is a mission statement or interfaith statement that we like to read, so I'll go ahead and read that now. This is an interfaith community. Whatever our individual belief, it can be freely expressed here with no apologies. If we are invited to offer a prayer in this setting, it should be offered according to the tradition with which we identify. If we are invited to speak on a subject from the perspective of our tradition, we are free to do so without fear of offending those who come from another tradition. We come together as people of faith to learn from each other that we might better understand the multiplicity of faith traditions in our city and in our world. And as Michael mentioned, at this point, we usually have a meditation to help all of us feel a little bit more grounded for the day. And for this morning, we're going to read I will read the prayer of St. Francis, which I think is familiar to all of us. Before I do, I find that as the day goes on, it is harder and harder to find a few seconds of calm or quiet. So I'm just going to ask us to hold silence just for 10 seconds to take a couple of deep breaths and gather ourselves, and then I'll go ahead and read this. Lord, make me an instrument of your peace. Where there is hatred, let me sow love. Where there is injury, pardon. Where there is doubt, faith. Where there is despair, hope. Where there is darkness, light. Where there is sadness, joy. O Divine Master, grant that I may not so much seek to be consoled as to console, to be understood as to understand, to be loved as to love. For it is in giving that we receive, it is in pardoning that we are pardoned, and it is in dying that we are born to eternal life. Amen.
Thank you, Kaushik, and thank you for your continued leadership and commitment of time to join us each week and to make a contribution that is so rich. Bless you. Dr. Aragon, we welcome you. It has been some time. At the outset of these briefings, you came and you guided us, and your guidance was very, very helpful. Time has passed, circumstances have changed, and by providence, just yesterday, we received a revised health order. So the timing of your presence here could not be more providential. I did look at the order yesterday. It's 102 pages, and we found the references to the religious community in an appendix. And so what the council has been trying to do since the beginning of the pandemic, the outset, is we have been conveying all of the information we've been getting from you to our 800 communities of faith and religious institutions. We welcome you today to give us an overview of where we've come, where we're going, and how the faith community is impacted by, especially right now, the revised health order. The floor is yours, Dr. Aragon.
Okay, thank you. I'm going to go ahead and give a slide presentation, and then I'll take the questions that you've prepared. So we can go ahead and put up the slide. Okay, so we can go to the next slide. And first of all, I want to thank everybody for giving me this time and opportunity to share with you updated information. We've learned a lot even since the last time we've spoke, so hopefully I'll try to incorporate some of that. In some ways, things are getting better, but in some ways, things are becoming more challenging as we open things up. So I want to just share with you the whole picture. One of the challenges that I have is part of my job is to keep an eye on everything, especially from a public health perspective, to really look at the whole ecological process of how this virus circulates through the community and has impacts on all of us. And I know that it has different challenges for different communities. And sometimes for me, it's very hard because even though we try to treat everybody as equally as possible, it's not always possible to do that. And so sometimes there's frustrations. And so hopefully going through just through these explanations, we'll give you an idea of what we do. Next slide. So I'm going to just review a few health indicators. Next slide. So up to now, we have over 11,000 COVID diagnoses in San Francisco. We have 104 deaths, and we've done over 500,000 COVID tests in the city. Right now, we test more than any location in California, and I believe we may be one or two in the top 2 or 3 for the United States per capita testing. Next slide. So there have been some changes. One of the main areas that we look at is based on the new state blueprint for a safer economy. This is the new framework that the state has put out that's really giving us the overall guidance of how we're opening everything up. It's based on the case rates and the test percent positivity. And I'll cover that in more detail in a later slide. We continue to look at hospitalization trends. We calculate our effective reproductive number, which is a very important concept that I'll review with you again. And we really look at 2 other areas, and that is our public health and healthcare readiness, and then our organizational readiness across the communities, whether it be businesses, community-based organization, churches, all of this, we want everybody has to be ready. So all of these 5 areas are really critical. Next slide. So this is a slide that's updated every few weeks, just to give you an idea of how San Francisco has done in general compared to most locations. So if you look at our cases per thousand and also deaths per thousand, you'll see that per capita we're doing better than most comparable places in the United States. And one of the reasons why it's important to remember this is that it gives us an idea of what could have happened in San Francisco. So if you look at, for example, in New York City, you'll see there that their mortality rate per 100,000 is over 227 per 100,000. So you can see compared to ours, which was 10 per 100,000, many times higher. We do not anticipate that any location in the United States would ever experience what New York experienced. And part of the reason is that we actually know a lot more about the virus. Back in March, when we shut down, one of the reasons we shut down is because we didn't know enough about the virus, so we had to go to the most drastic measure was to shelter in place. As we know more about the virus, we're more focused on how do we prevent transmission through the knowledge that we've gained, and how do we go ahead and manage the risk and open things up, taking into account the risks that are inherent in the different activities that we open up. And then you'll see we also do more testing than other locations as well. That also has implications for how the state assigns us a tier. Next slide. Oh, back one. Oh no, we're going forward too many. There we go, stop there. So the effective reproductive number is the average number of secondary cases that an infectious case causes during their infectious period. So you'll see that early on, before we shut down, the effective reproductive number was about 3.5. That is very, very high. And when you have that many people being infected, that's what gives the explosive epidemics that we saw in China, New York, Italy, Spain. We're seeing this in other parts of the world right now, like in Mexico. You'll see that our shelter in place, you'll see the arrow there, shelter in place, it started going down. We started restricting activities before we sheltered in place on March 17th, so we already started dipping down. So just the fact of just making large gatherings go down, we got down to 100 before we actually did the shelter in place, and then it continued to go down. When it goes below 1, that's good news, because when it's above 1, it's a positive feedback loop, and it's going to, the virus wants to grow exponentially. And when it's below 1, it's a negative feedback loop, and it pushes the virus, it pushes transmission down. And that's exactly what we want to do. And then you can see here that we had a surge in May. This happened after Memorial Day. So you remember all those gatherings that happened? And then you see the surge, we went up above 1, and we did not shut more down, we paused, and then we really focused on educating the community about what to do to eliminate risk. And then eventually we've come down. So we're about 0.9 right now. We want to get lower. We're beginning to open things up, and so we're getting nervous. And I'll share with you some of the concerns. I'll share with you why I'm nervous. Next slide. And this is just another depiction of this. This is a couple of weeks ago, but it gives you the big picture. You'll see here on the left-hand side the cases, and you'll see that we had our second surge on the left-hand side of the left curve. You'll see there is where we flattened the curve. And then you'll see then we had a surge. And then on the right-hand side, we have hospitalizations and ICU admissions. And again, you'll see we had our first surge. The first surge is different than the second surge. The first surge, we did not have the knowledge that we had, so we really had to shut everything down. The second surge, we pushed through it. We didn't shut down more. We just paused. And we managed the risk. Next slide. So what the state has done, they've created a new way of assigning risk to different counties to guide how to open up. Before, it used to be you were on the watch list or not on the watch list. Being on the watch list is equivalent of being in purple, the tier 1. Being off the watch list means that you get assigned to one of three other tiers. Now, what they're using is that they're using the cases per 100,000. And if the other thing that they're doing is that if you're doing a lot of testing, they downweight the rate. And part of the reason, the rationale they gave for that is they want to discourage counties that may decide to test less to push their case rate down. And so there's sort of a penalty. So it turns out that if you're testing less than the average, they give you a positive multiplier, your rate goes up. If you're testing more than average, and we're testing more than everybody else, it gets pushed, that case rate gets multiplied, in our case, by 0.6. So it turns out that San Francisco has no problem testing because we're very focused on testing. And we're very focused on mitigating the risk in the community so that we can prevent suffering, but also open up activities that people really cherish. Now, what we're doing is that because this adjusted case rate really reflects an adjustment that really doesn't apply to our city, because we're already testing. We'd be testing a lot anyway. There's no reason for us to actually really adjust. We focus on the epidemiologic risk. So we actually look at the unadjusted rate that really reflects the transmission in the community. And then we have test percent positivity. So the strategy that we're using is that when we get assigned a tier, so let's say when we were assigned to the red tier, because our adjusted rate put us in red, but our actual unadjusted rate still had us in purple. So we continue to manage the risk as if we're in purple. And so the way that we're doing this is that if we're assigned in red, everything to the left can open up. So if we're assigned tier 2, anything in tier 1 can open up. When we're assigned in tier 3, everything in tier 1 and tier 2 can open up. And when we get assigned to tier 4, everything in tiers 1, 2, and 3 will open up. We're not automatically opening up everything in the tier that we're assigned, because we know that that rate doesn't really reflect the actual burden of transmission in the community. So it could also be interpreted as us being extra cautious or more health protective, and that's true compared to the framework. But we are looking at our actual risk and to see where that is. But that gives us a way to help you understand how we're moving forward. Next slide. And so the other thing that we look at, so that's the big picture. We get assigned to a tier. Everything, every other tier that has a lower number is open up. But we also look to see within the activities to see what else we can mitigate, how else we can mitigate risk. And I'll show you some examples later on. And I think when I go through the examples, it'll help you understand, because the concepts that I cover apply to everything we do, and they apply to your personal life. Everything I'm talking about today, you can take home and use with the folks you live with. So we really want, as much as possible, want to push activities outdoors, and you'll see why later. And then we focused on lower risk indoor activities. Lower risk indoor activities, for example, in a barbershop, where you have this one-on-one, where if one person were infected, they're more like, if they do transmit, they're likely to transmit to a small number of people, because they're only dealing with one person, and so the risk tends to be lower from that perspective, even though indoor risks are higher. Then you have higher indoor risk, and then you have the highest indoor risk. So higher indoor risk are things where people are spending time indoors. There's a possibility that the mask can be removed, or that there may be poor ventilation. So the combination of these things can cause higher risk. And then the highest risk is going to be basically taking that and just imagining hundreds, thousands of people coming together indoors. It's going to be very high risk. Next slide. Keep going. Next slide. So the other thing that people ask me, and we're gonna come back to that. I'm going to take a slight detour just to tell you a little bit about how we make orders. So just to give you at the biggest picture, just to let you know, so everybody probably remembers that the government can only do three things, which is collect taxes, wage wars, and regulate interstate commerce. All other powers are vested into the states. And the states have what are called police powers, and it's police powers that's used for public health authority. So the ultimate power is at the level of the state. California is a big state. We now have 40 million residents of California. And so California has a tradition of delegating police powers for health down to the county level. And within the county level, a few cities go ahead and decide that they want to participate in the use of that power. And so you'll see a few city health departments. So we have 58 counties, 61 health jurisdictions. So it includes cities of Berkeley, Pasadena, and Long Beach. San Francisco is the only city and county. And that does change how things happen, because for the vast majority of counties, health authority is dealt with at the county level. So the health officer and the health department operates at the county level, and they work under the Board of Supervisors. And then they work with the cities and the unincorporated areas. So for example, Los Angeles County has to work with 88 cities, 88 mayors, and all those unincorporated areas. San Francisco is unique because we're a city and a county. We cut through all that bureaucracy. The difference is that the health officer, rather than being part of the Board of Supervisors, is actually under the mayor, because I work for the Department of Public Health. My function is a health officer. The health officer is a state function, so I'm an agent of the state, but I work for a local health department. And then I'm under the executive branch of the mayor. So that gives you a little bit of an idea. And it gets confusing because I have these vested powers from the state, but the ultimate authority is still from the state. So if the state health officer decides that San Francisco is not doing the right thing, the state health officer can come and override. In general, that doesn't happen unless there were some egregious bad decision making happening at the local level. Every county in California has to have a physician health officer. Next slide. And I'm just going to go to the second bullet here. So health officers, one of the major areas we focus on is communicable disease control. So people know about sexually transmitted infections, HIV, tuberculosis, measles, all these things. And of course, sometimes public health infectious disease emergencies happen. So it says here, health officers are authorized to control contagious, infectious, or communicable diseases and may take measures as may be necessary to prevent and control the spread of disease within the authority under their jurisdiction. So health officers have broad authority, but the broad authority is not unlimited. It has to, we work with the city attorney to make sure that everything that we do is within the Constitution of the United States. And what I basically do is I approach this from a public health communicable disease perspective, and I try to figure out, what can I do? What's the least restrictive thing I can do? Because that's part of public health, is we don't want to do the most restrictive. We want to do the least restrictive activity that we can do to contain this infection. And how can I do it within the legal framework of the U.S. Constitution, California law, and then the ordinances that we have? How can we leverage what we've already created in San Francisco? And sometimes we have to come up with something completely new and different. And the shelter in place, a lot of things we've seen with COVID have been things that have been very, very, very new. But we do work very closely with the city attorney, and the city attorney is always consulting with the state lawyers, and they're trying to make sure that what we're doing is the right thing to do from multiple perspectives. Next slide. So when we do a health officer order, we start with a blueprint for a safer economy. So I showed you the tier. I showed you how we've adapted the tier to San Francisco. We're being more health protective. And then health officers in California generally run the public health component of health departments. So the San Francisco Department of Public Health is a health agency that has multiple different areas. Like, we run 2 hospitals, so we have a whole healthcare system. I run the public health component of that agency, and that's true across the counties. The health officers usually run the public health services, and so we really depend on the subject matter experts that we work with to really give us guidance. So we work with environmental health, our communicable disease experts, pediatricians. We leverage expertise from UCSF. They've been a tremendous help to us in terms of dealing with this. We work with a city attorney to make sure that we have what are called health orders, and then we have what are directives. Directives are more like, it's like a guidance, but it has legal authority. So when we have a directive, it says, you have to do this, and it has legal authority. The order points to the directive, and what we adapt as we learn more is the directive. Information and guidance will come out with tip sheets and other information that may be best practices, recommendations, but not things that are legally binding. And then we work closely with the Office of Workforce Development, the Economic Recovery Task Force when it was operating, and they interface with a lot of different communities, including the Interface Council, so that we can get feedback from as many people as we can. And believe me, we get a lot of feedback. I'm really fortunate that we have teams of people that spend a lot of time working through the details. A lot of people reach out to me individually. I try to meet with different stakeholders as much as possible to really understand all sides of the issue. At the end of the day, what I'm trying to do is, and what everybody's trying to do, it's not just me. We're all trying to get to the place where we have a vaccine. This is a bridge to the vaccine. We want the least number of people infected. This virus is like no other virus. If we're learning that this virus takes over your immune system, upregulates receptors that allow entry of the virus, and pretty much attacks almost every organ that has these receptors. They're called ACE2 receptors. So it affects not just the lungs, the heart, the kidneys, the brain. And for a small percentage of people, we do not know which organ it's going to invade and cause. So we have people who are, it's predominantly their brain that's impacted. We have people who it's predominantly their heart, some it's predominantly their lungs. And some they've developed a kidney failure. People, the blood clots, so people have had gangrene from thromboses. So this virus is a very dangerous virus. All of us have to take it very seriously, and we do not know the long-term effects of this virus. And that's part of what scares us, is that we've only been in this pandemic now really since January, and then so we're just getting started. There's a lot to learn. There is some hope because vaccines are in phase 3 trials, and hopefully by the spring we're going to start vaccinating folks. And I think that's my goal, is to get I think of the city sort of like my family at home. My goal is to protect us collectively, to protect us, so that we can get to the vaccine, so we can go back. That means that all of us have to make sacrifices. And I think at the end of the day, your family appreciates it when we come together to really protect the family. We don't think short term. We think longer term. We think bigger picture. We want everybody around. We want next year at this time, I want to be here. I want to do this in person. That would be awesome, that we all got together in person. Next slide. Keep going. I'm just going to show you a little bit about this. I put this slide together because we were about to open up indoor dining, but these concepts apply really universally. And if you look at those 14 risk factors for transmission, everything from mobility, networking, contacts, when you're thinking about contacts, the number of people, distancing, duration, what the activity is, you'll see there eating, drinking, talking, singing, whether the face cover is removed. Then we get down to hand washing, indoor setting, ventilation, and fomites are inanimate objects. Think of it like doorknobs, pencils, and pens. You'll see that indoor dining has all of those, but so do a lot of other activities. So if you're not removing the face covering, you may have 8 out of those 14. And so next slide. So indoor setting, again, even though this was made for indoor dining, again, it applies. Indoor setting with possible poor ventilation, mixing with persons outside your household. If a face covering is removed by anyone, the virus gets, when you breathe, if you're infected and you have no symptoms, the amount of virus that you carry on you, whether you have symptoms or not, is high. It's the same. So just speaking, breathing puts out the virus in these tiny particles. Especially when you raise your voice, you put out more. When you sing, you put out more and smaller. So the smaller and more that it is, it floats away, and it goes beyond 6 feet. To give you an idea, and you can even do this experiment outdoors, but you can really, if you're indoors, if somebody's smoking a cigarette, if you can smell that cigarette, you are breathing their aerosols. Does everybody, I hope everybody sort of gets that in your mind. If you can smell that cigarette, you are breathing in, you are inhaling in what came out of their mouth. These aerosols spread. So the only hope that we have of doing anything indoors is that there has to be 100% masking, distancing, and good ventilation. That is the only hope. If one of those factors are not done, you're putting everybody at risk. And this is what people are calling super spreader events. It used to be, the thinking is really changing. It used to be that we used to think, oh, there's this individual that's a super spreader. It's probably not in the individual that's a super spreader. It's a asymptomatic individual in a setting that optimizes the transmission of aerosols. So a super spreading event is more likely to be in an indoor setting, where there's poor ventilation, and a person who's asymptomatically infected and is not wearing their mask. And so the greatest respect that you can show to all of us is that when we're together, the greatest respect that we can show to all of us is to to make sure your mask is on. And that applies to everybody, okay? And the other thing I want to point out is that, and this is where I know it's hard for folks to understand, is that the virus is a virus. It doesn't know, it takes advantage of every vulnerability that human beings have. And some of our vulnerabilities are socially constructed. And so we behave in ways based on social customs or cultural customs. And the virus takes advantage of those vulnerabilities. It doesn't know, it's not picking one group versus another. It's just taking advantage of what can happen using basically physics and duration of close contacts. Next slide. So when we start thinking, and this is true when you start thinking about the churches, places of worship, there is a systematic way that we think about it. Every way at the top, you sort of try to design your system to minimize the virus getting into your area, having engineered controls if the virus might be circulating. So that's why you're seeing a lot more emphasis on ventilation. Administrative controls instructing people what to do. So you'll see that in the orders, the directives do not permit indoor singing, but we say, okay, we'll let it happen outdoors, but not indoors. And then there's personal protective equipment. So there is there's an article here. There is a very systematic way of thinking about this. And sometimes it's good to talk to folks who spend more time thinking about this to help you sort it out. Most of it you can do through common sense. The big things you can do through common sense. Let me go to next slide. And I think this next slide is probably the most important slide because it really summarizes everything that I want you to take away and to take home to your families and your kids. And so on the right-hand side, you'll see an infected asymptomatic person. That person's not wearing a face covering. They're talking. They're putting out big droplets that fall to the ground, that may be contaminating surfaces, and then they're also putting out aerosols that actually float beyond 6 feet. We tell people 6 feet. The whole 6 feet was based primarily on the concept that the SARS-CoV-2 virus was primarily driven by droplets. We now know it's more than droplets. Aerosols is playing a big role. So you'll in anything that I write, I always say at least 6 feet. But the truth is that indoors, it's less about 6 feet. You want at least 6 feet, but you absolutely want really good ventilation. And so what happens in this bottom one is that if everyone's wearing a face covering, then you're creating a better situation. The face coverings are never 100%. So a good surgical mask might contain up to 90% of the aerosols. Just a regular face covering that's not very great might contain maybe 80% of it. So you still have aerosols coming out. So even if 100% of people are wearing a face covering, those people are still putting out aerosols. So that if you're in an enclosed setting, that aerosol is building up if there's not ventilation. If the air exchange the air is not being exchanged. And so wearing a face covering protects others. It also protects you, because if you happen to be close to somebody who has a large droplet, so it can prevent the large droplet from going in, and it might also reduce the number of aerosols that you inspire. So so really it does protect others, and it also has some protection against you, protection for you, protects you from others. The other thing I want to mention here is that in public health, we focus on mitigating the average risk across the population, right? However, individuals may decide that they want to reduce their individual risk even more. So you will see, we tell people who are older, have medical conditions, don't go indoors, don't be around crowds, don't do things that put you at risk for acquiring the virus, because you're much more likely to do worse if you get the virus. Some people will go ahead and put on N95 underneath the mask here. More people are using N95s because of poor air quality from the wildfires. It's the same N95 that you would use for a wildfire. You can put it right under your face covering here. So this just summarizes here. This just on the right hand side is just a depiction of what we think about. Ventilation, opening up the windows, not recirculating air. If air is being recirculated, you have to have a HEPA filter, a MERV13 filter to filter out viruses, small particles. There's other engineering solutions. Portable air cleaners. So for example, in a classroom that may have very poor air ventilation, you can have an air cleaner that has a filter that will purify the air and take anything that's any virus that's in the air and take those out. This is one of the more affordable ways of getting a room. So I want to go ahead. Let's if you remember this slide, it will help you a lot. We do have a guidance on ventilation, and there's always more that we can provide for folks, because it is a slightly complex topic, and it's really challenging, and there are some simple solutions. But you have to also just accept that you may not be able to mitigate the risk in a certain setting. So I did, so if I'm going to go indoors and I knew that the place is not doing what they can to mitigate the risk, I would not go in a building. And if I had to, for a reason, I would probably use respiratory protection. But this is how serious it is. And this is what we're most concerned about. We're now opening up activities that are we're now moving into our high risk, which is more of the indoors, where you have people who are together for prolonged periods of time. It's less so than somebody who's walking in and out of a store. They're not there for an extended period of time. They're moving through. Those areas also have risk as well. But we're talking about areas where people are coming together for longer periods of time, where this becomes a lot more risky. And the other thing I tell folks is, this is all temporary. All the mitigation measures we're doing now is temporary. When a vaccine becomes available and we build up immunity through the vaccine, we're going to be able to and we get the infection rate down. It gets down so tiny, so small, that we can do higher risk activities, and we'll be able to manage the risk at that time. At this time, we don't have enough tools to manage the risk, so we have to rely on the core strategies that we have. Next slide. Guidance on singing and chanting. So I'm just going to read. This is from the directives. Consistent with the state's health guidance, singing and chanting activities are not permitted during an indoor religious gathering at this time, even while wearing a face covering. These activities, in particular singing, greatly increase the distribution of contaminated exhalations, which increases the potential for broad transmission of the virus. Houses of worship must not organize an event that encourages participants to engage in singing, chanting, and shouting, or otherwise encourage participants from doing so during any indoor religious gathering. Next slide. If a leader or participant is engaged in prolonged speaking, such as during a sermon or reading, they must speak at least 12 feet from people who are not part of their household at all times and must wear a face covering at all times, unless otherwise provided in this directive. Leaders and other speakers should not raise their voice and should use microphones or other public address systems whenever feasible. I think in all of us, in our positions of leadership, we have to model the best behavior. We have to model the best behaviors, because when we're protecting our family, we're teaching others how to protect their family, because they're going to go home. And if we help them build the discipline that's required to protect our families, it helps them to go home to protect their families. So this is really critical. So I'm going to go ahead. That was my last slide. I know there's a lot of questions. I try to incorporate a lot of the answers in the presentation. So hopefully that'll do. And I'm willing to always come back again. I want to make sure that we answer most of your other questions. I'll be really brief because I know you have a lot. Sorry.
Thank you, Dr. Aragon. This was a comprehensive, informative, and helpful presentation, which we will share with our 5,000 e-subscribers by day's end today. We have 14 questions that have been submitted by some of the most prominent faith leaders in San Francisco. I will pose them to you in alphabetical order, unedited. Some of them might be repetitious, so you can judge your answers and responses that way. Just to note that these are the opinions of those stating the questions and not those of the Interfaith Council. Let's begin with the Right Reverend Dr. Mark Hanley Andrus, Bishop of the Episcopal Diocese of California, who asks, many congregations in San Francisco have limited ventilation. How does this reality affect the choices about indoor worship?
Great question. Great question. And I think that's one of the challenges that we have. I would say one of the best things that you could do if you are gonna have indoor services, keep the group small, spread them out, and think ventilation, ventilation, ventilation. Open the doors, open the windows. You want to have as much air exchange as possible. And there is guidance online that can help you with that. What I can do, Mr. Pappas, I will send you. There are some websites that help lay people understand more what they can do around ventilation, and we'll make sure you can get that. You can have that.
Please send that so that we can share it.
Yep.
Next question is from Father Mesrop Ash, the parish priest at St. John Armenian Apostolic Church. He says, Orthodox churches such as ours require communal singing and chanting to conduct liturgy, if not by the congregation, then at least by the choir. Hymns and chants cannot be omitted from our services and must be sung live, not played back from a previous recording. We would appreciate clarification regarding guidelines associated with communal singing. If choir members wear masks or plastic face shields or use partitions, would it sufficiently mitigate concerns about viral spreading?
Based on everything that we know about the virus, the answer is no. And the problem is that these aerosols escape from your mouth. When you're singing, they're so tiny that they will float away and they will go farther away. That's why the state at this moment, the state is prohibiting singing and chanting indoors. We're always happy to meet with folks to think about alternative engineering. You have to be creative about thinking about how you might do this, having people outside the building in other rooms, other things that you can do that use technology, but not singing. Not right now. The state does not permit it for good reason.
Okay, the next question is from Father Greg Bonfiglio, pastor of St. Ignatius Parish. It's a three-part question, of course. Good Jesuits. The first part is, as we open our church for public services per the guidelines of the City and County of San Francisco and State of California and the CDC, it will be a reality that many of the people who come to our services and will volunteer to help will be older people in vulnerable categories. Do you have any additional guidance to offer us to keep these citizens safe despite any risks to their health? They are not going to stay home. How can we be extra careful?
Yeah, so I would suggest trying to be creative. For example, some supermarkets, they will have a time of day where if you're of a certain age that you can come, so you can come and you're not around a lot of folks. Probably, so I would really try to be creative, and you might do something like that where you have special services for people of different ages, and then also there's just a lot of need in the community. So if they can work outdoors with the food pantry, other activities that are happening that are helping meet all the social needs that have been created by this. So it's both a religious service, but it can be done in a way that's safer if you could put them to work outdoors. That would be the safest. That would be the win-win.
We have been collecting contact tracing information for each person who comes to our services, both indoor and out. If we later learn someone who attended a service tests positive, what are the steps we should and are obligated to take?
Yeah. So what I'm going to do is I'm going to have to get you I didn't have time last night to get you the right phone number, but we'll give you. There is a sheet that has the right phone number that you can call to report a case to get the investigation started. So I'll make sure to get you that.
Thank you. And the last part of the question, if a person presents with symptoms at our church, besides simply turning them away, what procedures should we follow or suggest that they follow?
Yeah, the best thing to do is to really ask them to go home and to contact their physician, their healthcare provider, to get tested. If they don't have access, of course, they can always call the health department, and then we do have city test SF, so they can always call 311. They may be mildly ill and feel well enough to go ahead and just go get tested.
Okay. From Raphael Brenner, Director of Jewish Community Security and Jewish Community Federation and Endowment. The first part of his question refers to the virus. In the initial weeks of the pandemic, we were told it could take up to 14 days to manifest symptoms. Has that estimate changed?
It's anywhere between 2 to 14 days. On average, it's really about 5 days. So most people, usually by day 7, most people will have already developed symptoms if they're going to go on to develop symptoms. Some of them don't, and you have a whole group that are asymptomatic, don't develop any symptoms, but are carrying the same amount of virus.
I believe you responded to this question, but given the prohibition on singing and chanting, the situation seems largely unchanged. What are we missing in the latest order?
Yeah, we're not right now. Unfortunately, not at this time.
Okay. From the Most Reverend Salvatore Cordileone, Archbishop of the Archdiocese of San Francisco. Both Mayor Breed and City Attorney Herrera have made it clear that the San Francisco health officer alone has the authority to decide what health orders of the City and County of San Francisco will include. When shelter-in-place orders were first being issued in March, it was the health officer himself, yourself, who was making the announcement. Later, Mayor Breed was making the announcements about the new health orders as they were being issued. Most recently, City Attorney Herrera made the announcement about the latest health order that was to take effect October 1. Why are different city officials making the announcement of decisions belonging to another city official, i.e. the health officer, and what determines who makes these announcements as each new health order is due to be issued?
Yeah, so that's one of the reasons why I covered that in the slide presentation, sort of the structure. So I'm an employee of the health department. The health department is under the mayor, and so the elected officials really the elected officials run components of the city, and so they decide how they're going to communicate to the general public. I also think they help protect me because I'm so busy now. That they protect me from having to do a lot of public speaking so that I can focus on the job. And then for me, I'd rather be in this environment where I get to speak more directly with folks rather than having a 15-minute press conference. So I do spend a lot of time interacting with stakeholders, but that's the only reason.
Okay. From Reverend Elizabeth Eckdale, lead pastor at St. Mark's Lutheran Church. Again, a two-part question, nuanced on something you've addressed. Can we have one song leader sing the hymns and liturgy using the appropriate safety measures? The rest of the congregation would not be singing. And can we pray out loud together and respond together in our liturgies, the Lord's Prayer, concluding prayer with a unison amen?
So the answer is inside no for singing. And I think we're gonna all have to adapt or move outdoors. I think that's the safest thing to do is to adapt or move outdoors. Last thing I want to point out is that indoors you can have up to 25% or 100. Outdoors you can have up to 200, You cannot have both going on at the same time. So if you're planning an event where you're anticipating 200, you can't have that one indoors. You'll have to have it outdoors. But that doesn't mean that you can have a simultaneous 100 per person, because now it's getting up to 300. So you have one or the other. We're trying to incentivize outdoor activity.
That's very helpful. From Father Paul Fitzgerald, president of the University of San Francisco, what efforts are being made to accelerate the turnaround time for safety plans submitted to the San Francisco Department of Public Health?
So we're not approving safety plans from the faith-based communities. There's too many for us to approve. So that's why we're providing detailed guidance. You really do need to have everything, and you need to have all your plans in place before you open up. That's the most important thing. We do have the legal authority to come and ask, can we see your plans? But we're not going to be reviewing and approving plans because there's too many. And I think let me leave it at that.
From His Eminence Metropolitan Yerasimos of the Greek Orthodox metropolis of San Francisco, the San Francisco faith community has been more than cooperative in complying with COVID-19 related county health orders. It must be stated that restrictions imposed upon the ability of houses of worship to operate have seriously curtailed our free exercise of religion. When we raise the issue of equivalence, why, for example, does the county tolerate mass protests but does not permit houses of worship to operate, our voices are not heard or are ignored. Going forward, and for the duration of this pandemic, we would like to participate in the formulation of a policy as it affects our houses of worship. Are you, Dr. Aragon, willing to participate in this discussion?
I'm always open to participating in discussion. We have to just figure out how to do it efficiently, just because of time constraints. Yeah, always happy to work. What I focus on is the transmission biology of the virus, and then I let the lawyers sort of figure out what we can do constitutionally. And then we have guidelines from the state. So we try to balance all of those. So we're not trying to pick one against the other. Sometimes contradictions emerge when you're trying to balance so many competing trade-offs.
From Reverend Marcy Allglass, the pastor and head of staff at Calvary Presbyterian Church. You can see how important singing is. My question would be if there is any recent data about singing groups. We are planning for how to return to the building as guidelines allow, but want to be able to sing if we can do it safely. If we sang one hymn in masks at the end of the service while people were appropriately social distanced, would that work? I believe you've addressed this.
Yeah.
From Pastor Maggie Henderson at Old First Presbyterian Church, I'm overwhelmed by the amount of info from the city, my national church, church musician organizations. I wonder practical things in a worship. What is best practice? What is fear speaking? What needs to happen? I wonder about no paper allowed in worship, bulletins or hymnals, no pew cushions, issues of ventilation. I don't know how any churches that have air conditioning and the windows in sanctuary many times do not open. What about bathroom use? What is the recommendation on cleaning after service? I hear anything from everything is wiped down. Let to sit for 3 days or more. Deep cleaning, but what does that mean? Our cleaning service has a new machine that is supposed to do deep cleaning, sanitize, but are there really anything that is helpful or just a hope?
So really quickly on cleaning, the good thing is that the virus, just regular disinfectant cleaning works. Highly touched surfaces is sufficient. Pay attention on the big things that I mentioned. The big things are physical distancing, indoor air, ventilation. When you send them that slide that I sent, if you focus on the big things, you will get 95% of your value by focusing, using those principles to design everything that you do.
From Reverend Vanessa Rush Southern, Senior Minister at the First Unitarian Universalist Society of San Francisco. Are you saying socially distant worship leaders and preachers can't take off their masks while leading a liturgy? I'm interpreting the limit on singing because of the dangers of corporate singing. Can congregations have socially distant soloist masks during performances only of the kind that are common in worship, generally 6 to 10 minutes total in an entire service? If the answer is no, the answer would be different for those in congregations who will not be opening their services to invite members back, but continuing with simple live stream and 12-person limit that we are currently under.
Yeah, so I think our most important role as a leader is to model the behavior that we really want everybody. So leaders modeling the behavior when we're in these settings, especially when they're truly high risk, the leaders have to wear masks. I don't know how else to say it. It is modeling what we need. It helps everybody. It's really critical. We see that not happening at the national level, and it creates more issues.
We have three very quick questions. Rabbi Jonathan and Beth Singer, senior rabbis at Congregation Emmanuel. We at Congregation Emmanuel are so appreciative of the city's work to keep us all safe during this unparalleled time in our history. We understand the desire to gather again, which is central to our mission. But at no time do we want to let enthusiasm to do God's work bring harm to those who come to us for spiritual support and connection. With this in mind, as the new regulations come into being, we have at our temple footprint 2 sanctuaries, one with 1,700 seats, one with 400 near each other, plus a courtyard that can hold 150, where we can also hold outdoor services. If permission to have 25% capacity usage comes into play, will we apply that to all 3 separately, 25% each, or the totality of the space?
So that is addressed in the directives, because we recognize there's going to be places like that really have separate areas. So read the directives carefully. There's a whole section that addresses that specific question. And then if you have any other questions after you read that, please have them contact me.
From the very Reverend Dr. Kirill Sokolov, Dean of the Holy Trinity Cathedral. Could you please say more about the suggestion in best practices to screen parishioners using Department of Public Health form or equivalent before entry into a place of worship? Our beautiful city museums like the De Young are simply advising visitors to not enter the museums if they have symptoms. What is the science behind having different, stiffer requirements for churches that will have so few people, relatively speaking, than the other cultural institutions? It was already startling and disheartening to those of us who are working hard to defend all the safety practices that museums receive preferential treatment to places of worship in terms of September's reopening schedule.
Yeah, so we took those areas that we consider higher risk, and we're asking for screening. So for example, if you go to a restaurant, so we're asking all indoor dining to do the same screening. So we're not trying to treat places of worship different. It's just in that category of higher risk. And so yeah, places like indoor dining also have to do that screening as well.
From the very Reverend Dr. Malcolm Clemens Young, Dean of Grace Cathedral. Our cathedral has an immense amount of space with 100-foot ceilings. Under what conditions could our choir sing again? It would be possible to separate them by lot of space. Would it be possible for the officiants and preachers to not use masks when we are recording church services for broadcast? It detracts from our presentation, and we see other churches online with participants who don't wear them. What plans should we be making for Christmas? Is it likely that some number of people might be able to be gathered for in-person worship then?
Yeah, so for broadcasting, that's a longer conversation. For people that are doing broadcasting, there are different scenarios that you have when you're bringing in small numbers of persons around masking. So we'd have to talk separately about that one. But otherwise, I would read the directives carefully. It did show up and did put it into the slide, so hopefully that's going to be sufficient. Hang in there. I wish maybe next time I'll bring different news. I know the singing was a real challenge one for everybody.
I think you saw that in these questions. I just
Yes.
have one last question. I know you have to depart. At the outset of the pandemic, the Economic Recovery Task Force, Department of Public Health, and the Mayor's Office asked for input from faith leaders on what they feel they need to do to reopen. We at the council harvested and compiled a great cache of reports that were developed internally by many judicatories and communities of faith and submitted them to you all. Are you using them and taking into consideration all of the health orders as they evolve?
I know that our team that works on this, they review everything that comes in. I can't speak to those specific reports, but I know that they're very thoughtful in terms of reviewing things. If there's anything that you want me to review individually, let me know. And if I have time, I'll try. Sometimes it's really hard to get through everything. But if we miss something, please please communicate with me more. A lot of what's happening with indoor worship was really driven primarily at the state level, and we just took our core San Francisco, just made sure that we codified it into the directives. So we take it as much as we can, but we don't. If I miss anything, please reach out to me, and I'll try to make sure that I'll look at it.
Dr. Aragon, thank you for your time. I know that we've gone over the time that you were able to give us, and we are very grateful both for your presentation and for answering the questions. So if you have to depart, please do that, and I'll close up the
Okay, thank you, everyone. Please hang in there, be safe.
Thank you, Dr. Aragon.
You're welcome.
I'd also like to thank Kaushik Roy, who is on with us, as well as our administrative and program associate at the San Francisco Interfaith Council, Cynthia Zambucas, and from the COVID Command Center, Joint Information Center Virtual Outreach Team, Coordinator John McKnight, Producer Lynn Mays, who was assisted by leads Sharon Walton and Hafisa Salebai. We're going to invite you all to join us next week as we drill down to consider the necessary sanitation protocols and precautions houses of worship will need to take to keep their congregants safe. This concludes today's program. Again, we will be sending out the recording, God willing, by day's end, and we would ask that you review it carefully. We'll also be sending Dr. Aragon's slide deck, as well as the links that he made reference to, so that you will have all that you need. If you have any further questions or are in need of clarification, please contact us, and we will get that clarification for you. This concludes today's program. God bless you and God keep you.